Good afternoon, everyone. My name is Morgan Gargiulo from the New England QIN-QIO, and I will be your moderator for today's webinar, taking a deep dive into the QPP Promoting Interoperability performance category. Before we get started, I wanted to go over a few housekeeping items. This call will be recorded for training purposes, and I will provide you with details on accessing that at the end of the webinar. The phone lines are currently on mute for the duration of the presentation. But I will let you know how to ask questions over the phone at the end. We will be taking questions throughout the presentation in the chat box at the bottom right corner of your screen. Just make sure to send your questions to all participants so we can keep up with the incoming questions. If you haven't already done so, I have just put the link in chat to where you can find the slides for today's presentation. So with that said, I will now pass it over to Leela to get us started.
Great. Thanks, Morgan. Hello, everyone. My name is Leila Blinsky. I am a Senior Program Administrator with Health-Centric Advisors, the New England Quality Innovation Network Quality Improvement Organization. And as Morgan mentioned, today's webinar is all about taking a deep dive into the Quality Payment Program Promoting Interoperability performance category. And we have lots and lots to talk about, big changes coming for 2019, so hopefully you will find this very helpful. Quickly, before we get started, I just wanted to share this brief disclaimer. All this content comes right from the Centers for Medicare and Medicaid Services. However, these slides were created by me, so if there's any inaccuracies, I apologize. Quick overview. As I mentioned, we're laser focused today on the Promoting Interoperability performance category. We'll first talk about the measures, the measure exclusions, the 2015 Certified EHR Technology Requirements, and special status considerations. We'll talk a little about the hardship, alternative payment model considerations, and I'll let you know about how you can get to the measure specifications. Lots of time for questions and discussion. I'll share some resources. And as Morgan mentioned, if you have questions throughout the presentation, please feel free to add those into the chat and make sure they go to all participants. And I will open the phone lines up at the end, and you're more than welcome to ask your questions over the phone. So first of all, the Promoting Interoperability performance category, if you've been in the QPP world for some time now, you're probably remembering that when the program first started, it was called Advancing Care Information, or kind of even going back further than that, all of these measures and a lot of the requirements came right from the Medicare EHR incentive program, or meaningful use. But CMS, in a few fashion, changed the name about a year ago to Promoting Interoperability. And just by that very name, you can kind of tell where CMS is placing a lot of emphasis. It's in interoperability. They want to see that patient records are being seamlessly transmitted between care providers, between settings of care, that patients can access their information easily. They can go right into a portal or other system, service, whatever the case might be in your practice or organization. Pull down maybe an after-visit summary, patient education materials. If they want to ask questions, they can just go in and type in their questions, send that along to the office, and have their questions responded to in a timely manner. So really, how is data, health information data, being sent back and forth and hopefully seamlessly, and then how are you measuring that? So new focus for CMS, or kind of a shifted focus. For 2019, this performance category probably has seen the largest shift in how, one, the category is structured, and two, the scoring methodology. So currently, the performance category accounts for 25% of your MIT score. The reason why there's an asterisk, which we'll talk about a little later on, is there are a couple different opportunities for reweighting of this category, so it might actually be 0% of your MIT score. But if it does happen to be 25% of your MIT score, in previous years, the way the category was structured was off of a base measure requirements, depending on the certification year of your electronic health records. And then from there, the specific set of measures that you chose. And there were three different options that you could select. You could choose the transition measures, which were either 2017 or 2018, and those really focused on, if you're familiar with meaningful use, the meaningful use stage 2 modified measures. And they allowed clinicians still using a 2014 certified system to be able to report and hopefully get a lot of points. The other measure set was the just straight either 2017 or 2018, either advancing care information or promoting interoperability measure set once the name changed for the category. And those were really looking more at meaningful use stage 3 measures and looking at clinicians and organizations that have already implemented a 2015 certified EHR. There was additionally an option if you were somewhere in between implementation during the year or your performance period and you wanted to do a combination of 2014-2015 certified technology, you could pick a combo measure set, which would allow you flexibility of choosing from both of those transition measure sets and the actual measure set itself for the category. So that was 2017 and 2018. On top of the base required, there were also opportunities for performance and bonus measures. That has all gone away. Well, maybe not the base requirement, but the performance and bonus measures have gone away. So in 2019, all eligible clinicians and organizations are required to use 2015 certified EHR technology. 2014 is no longer allowed. And you have to report on a minimum 5 required measures. And we'll talk about what those measures are. There are 2 additional bonus measures that are both really looking at overhaul. Also, a major focus for CMS is making sure that opioids are being prescribed appropriately and that patients that potentially have an issue with opioid dependence are also being monitored very closely. The security risk analysis, which has been in place throughout the use period and the first 2 years of the MIPS program, is still there. It is not a scored measure. We'll talk a little more about it, but you do still have to do a security risk analysis. You just won't earn any points for it. Luckily, the performance category remains at that 90-day continuous reporting period, so you can choose any 90 days throughout the calendar year of 2019. It just has to be 9 days. And I always mention it, but October 2nd, mark it on your calendar, is the final start date of a 90-day period calendar year. So if you haven't figured out what reporting period you want, you get kind of into September, really still not sure, you have to start by no later than October 2nd if you want to get that final 90 days. So here are the new measures. We'll go into each of these measures in depth, but I just want to give you a quick little overview of what we'll be talking about. So CMS is going back to, like I mentioned, kind of the structure of the Meaningful Use program where there was an objective, a measure, maximum points available. There's no threshold currently. You just get a maximum number of points. And then for this year, CMS is allowing a tremendous amount of flexibility in terms of exclusions. So if you take an exclusion for a measure, there's a good likelihood that that measure gets reweighted to a different measure within the performance category, allowing you to still get at least a handful of points for your performance in a different measure. And without further ado, we'll get into the specific measures. So in the objective of electronic prescribing or e-prescribing, the first measure is e-prescribing itself. This measure should look very familiar. Nothing has changed in terms of the measure description or objective. The only thing here is that this measure, so eligible clinicians and organizations that submit at least one permissible e-prescription during the reporting period will be eligible. However, there is an exclusion here, so if you have fewer than 100 permissible prescriptions during the performance period, you can take that exclusion. If you happen to take the exclusion, the 10 points possible for this measure get evenly distributed between the 2 health information exchange measures, which we'll talk about in just a minute. So the 10 points, 5 goes to one measure, 5 goes to the other. And just one last thing about e-prescribing before I move on. Keep in mind all of these measures where there's a specific number for the exclusion. So here's the 100 permissible e-prescriptions. When we get into the health information exchange measures, it's those transitions and referrals. If you're reporting as an individual, that 100 would be for just you as an individual. If you're reporting as a group, it would be 100 for all of the members of your group. So that group just has to meet 100 in order to be eligible for that measure. Okay. So the next measure in the electronic prescribing objective is actually a bonus measure So this is first the query of the prescription drug monitoring program. If you are in any state in New England, which is where our offices cover, all states are required, any prescriber is required to be registered with the state-based prescription drug monitoring program. They're all different names. In Massachusetts, it's the MassPat. I'm not sure what the other states call them, but anyway, you have to be registered. So this is a great one if your EHR has been configured in such a way that you can kind of seamlessly pull that data from the PDMP, Prescription Drug Monitoring Program, right into your EHR. It's not simply just going out and checking. It's that there's this kind of integration. So for at least one Schedule II opioid or other narcotic, that electric prescription is checked through the Prescription Drug Monitoring Program. And then there is this little exception, except where prohibited or in accordance with the applicable law. So in some states, you are not allowed to actually e-prescribe Schedule II narcotics. So if your state doesn't allow it, obviously this wouldn't be a measure appropriate for you. Because it is a bonus measure, it earns up to 5 bonus points. There are no exclusions and no reweighting. There is talk in terms of the final rule and future years of rulemaking for the Quality Payment Program and MIPS program in particular, that next year, so in the 2020 performance year, this measure and the measure I'll talk about in just a moment will actually be required. Now, because there are potentially state laws that mandate different things around the PDMP utilization, there's a good chance that there will be at least a few exclusions you might be able to take. Obviously, if it's not applicable in your state, you wouldn't be able to report on it. So just keep that in mind if you're working with your EHR vendor to integrate the PDMP. This is a great way to get bonus points, and definitely next year plan to have it in place because it more than likely will be required. The second bonus measure in the electronic prescribing objective is the Verify Opioid Treatment Agreement. As I mentioned, the two bonus measures are both related to opioids. So for this measure, it's for at least one unique patient that has a Schedule II narcotic prescription electronically prescribed using your EHR system. And this is the interesting part of this measure. So if the total duration of that patient's prescription is at least 30 cumulative days in a 6-month period, and that's a look-back period, not a looking forward period, obviously. You need to have that historical data. That's when you would be looking for that signed opioid treatment agreement and making sure that that agreement is in the patient's electronic medical record. So at least 30 cumulative days, and that could be multiple prescriptions over the course of 6 months. But if it all gets to 30 days, then you would be looking for that opioid treatment agreement. As I mentioned, also 5 bonus points and no exclusions or reweighting opportunities here. But similar to the previous measure, this more than likely will be included in the measure set for required measures for 2020. So just keep that in the back of your mind if you're working on this now, that you should have it in place by next year. All right, 2 fun measures. Don't hate the messenger. CMS has put a lot of weight on health information exchange. There are 2 measures in this objective. The first is the support electronic referral loops by sending health information. This measure should look very familiar to all of you if you're used to advancing care information, promoting interoperability, meaningful use. It is the measure that probably causes the most anxiety in clinicians and practices that we work with. So this is the sending the electronic summary care document. So for at least one transition of care or referral, and that's really important to keep in mind, this measure is not strictly looking at referrals. We get that question a lot. My practice doesn't refer patients out, or a specialty practice. That definitely could be the case if you are typically getting referrals into your practice. But this also is looking at those transitions of care. And those transitions of care are any time that patient leaves your setting of care for another setting of care. So if you're a specialist bringing those referrals in, but maybe you don't refer back out, when you send that patient back to their primary care physician or maybe other care provider, I'm not sure who it would be, that would be considered a transition. The other piece of this to keep in mind is the way that you document transitions and referrals within your EHR can dictate what your denominator looks like for this measure. And we always say go with your gut. If you look at this measure when you pull a report down from your EHR and you see that your denominator is maybe 0 or, 5, and you have a relatively large practice and a lot of patients are either coming or going to different settings of care or whatever the case might be, that probably isn't an accurate count. You'd want to work with your EHR vendor to make sure that you're accurately capturing all of those transitions and referrals, because that will dramatically affect, obviously, your numerator and your denominator based on how you're reporting those. So, all of that said, for at least one transition or referral, the MIPS eligible clinician sends the summary of care using that certified EHR technology, and it has to follow that CCDA document structure. There's a whole bunch of different sort of models you can follow, but CCDA, all those components that are required for this one. Similar to the EPrescribing measure, there is an exclusion for any MIPS eligible clinician who transitions or refers fewer than 100 patients during the reporting period could take that exclusion. If you recall, the 5 points from the EPrescribing measure would come to this measure, so it could potentially, if you have an exclusion, be worth up to 25 points versus just the standard 20. But if it does get, if you take an exclusion here, it's really interesting. CMS actually hasn't said where the 20 points get redistributed to. That is expected to come in the 2019 proposed rule, so we won't know until this summer where those points will get redistributed to, but just know that there is an exclusion and redistribution for this measure. The next in this objective is the support electronic referral loops by receiving and incorporating health information. Again, this should look very, very familiar. It's basically a fancy new name for the receive, request, and accept the summary of care document, as well as kind of baked into it the clinical documentation reconciliation measure. So CMS kind of just took a couple measures, merged them together because they were kind of similar, and we got a whole new measure. So also 20 points possible. This is also looking at those electronic summaries sent for referrals and transitions. The other interesting piece of this is also for patients that are brand new to that clinician. So that could be the referral. It could be a new patient coming in from, a different PCP to a new PCP, something of that kind of genre. Looking at all of those different patient data elements, so medications, medication allergies, and current problem lists, critical to have in your summary of care document. But again, those are expected components just in the basic CCDA as it stands. There are 2 exclusions for this one, so as I mentioned, similar to the previous, it's any eligible clinician who transitions or refers fewer than 100 eligible patients, or has fewer than 100 encounters with patients that they've never seen before. So all new patients coming in. If you take an exclusion on this measure because you, for whatever reason, don't have patients that meet the requirements, then the 20 points get reweighted to the other health information exchange measure, the one we just talked about, that support electronic referral loops by sending the information. It's kind of interesting how, if you go back and look, like I should do an arrow diagram of how all of the different reweighting works, because there's a lot of back and forth, very confusing. The next measure we'll talk about is the provider-to-patient exchange. Again, this measure should not look different. It just has a fancy new name. So provide patients electronic access to their health information should look really similar to that provide patients access to the portal measure. This is looking at unique patients that the eligible clinician gives either to the patient themselves or to their authorized representative access to some sort of portal where they can view, download, transmit. Again, there's that lovely measure that used to be in existence, view, download, transmit, and also access to patient education materials, any sort of communication with the clinician, so looking at that secure messaging component, really all of those different elements that used to be part of kind of the portal, let's call it the portal grouping of measures, is now just one measure. So you just have to give your patients access using whatever technology you have based on your EHR or your organization. There are 40 points possible for this measure, and there is no exclusion and no reweighting. So this one remains as it is. Just one thing actually before I go on. So an interesting component for this measure that we hear a lot about, for the older population, one of the elements here is that you can give access to a patient's authorized representative. So we get a lot of questions. Typically they come from clinicians that work in skilled nursing facilities, so maybe SNF providers that go in and do consults or regular patient care. How do they make this measure work? Because obviously, more often than not, those patients are not in a situation where they, one, usually have access to a computer, and two, are not really looking to be as engaged in the electronic side of their care, just because different generational elements of care, not something that they are looking for. So when you have patients in that circumstance, if you have a family member or some other individual that you could give access to, that's a great way to get credit for this measure. Unfortunately, because there are no exclusions, even if the patient declines, there's not a way to get credit for that. So just keep that in mind as you start thinking about, okay, I'd really like to get my performance up on this measure. What can I do? Think sort of outside the box about who is in that patient's life, who might be able to be an authorized representative and help with the data exchange. But sometimes it takes some really clever out-of-the-box thinking to get that one taken care of. The last of the objectives is public health and clinical data exchange. Again, this measure should not look different because it's been around for a while in many different iterations. So provide patients, that is the same name as the other one. This is not the correct name. I apologize, I got carried over incorrectly. This is looking at, it's exactly the same name, so Public Health and Clinical Data Exchange. For the MIPS-eligible clinician, this measure's changed a little. You have to report on at least 2 or take an exclusion. So of immunization registry, electronic case, public health registry, clinical data registry, or syndromic surveillance, if you can report to 2 of those registries or other exchanges, then you would report to those, and they're simply yes/no's. And definitely make sure you have documentation of the transition of data back and forth between the registry and yourself, if it's bidirectional, or unidirectional if you're just sending a registry like the syndromic surveillance. Now, if you can't report to 2, you have the option to report to 1 and take an exclusion for 1, or take an exclusion for 2. But you have to take action on at least 2 in order to take the 10 points for this measure. It's a straight 10 points. There's no partial credit. If you happen to take exclusions for both of the measures, then you would have the 10 points reweighted to the provide patient electronic access to their health information, the measure we just talked about with the portal. So that measure will go up to 50%. Again, much like the electronic prescribing, I didn't put the whole language for the exclusion, but it's really based on your regional state-based jurisdiction. Does your state have an immunization registry that you can send data to that's up and running? Some states are more advanced than others and have that capability, some don't. So just know it depends on when you can get that data across and who you're sending it to. As I mentioned, we'll talk a little bit about the security risk analysis. So security risk analysis is still required. You do not earn any points for this measure. It is attestation only, so that yes, no. This measure and the 2, technically the 2. The one I just talked about with the electronic submission of clinical data or registry data definitely have supporting documentation on hand. So reports. For security risk analysis, you need to either complete or update your security risk analysis annually, or if you're doing any sort of upgrade or installation of new technology, you need to make sure you're going back through, looking at the requirements, making sure that you have the appropriate encryption, that you're following HIPAA data requirements. Keep going through that and make sure everything's timing out appropriately, requiring password updates, all of that different information. We have seen a lot of organizations use the Office of the National Coordinator, or ONC's tool. We can try to get that link added into chat. I'm hoping one of my team members can look that up for me and post it. They have a great tool that walks you through all of the steps. It's free, which is excellent. Some larger organizations will bring in a consulting company, usually every 2 to 3 years or so, to do a new analysis, which would update all of their different findings. You need to also just make sure you have a mitigation plan if you find any sort of risks to the security of your patient health data. Okay, so what do you need to do to achieve success in this performance category? A quick little bulleted list. So the first is you have to report on all of the required measures, which are 5. You have to have at least 1 patient in the numerator. If you don't have 1 patient in the numerator, you would not be meeting the requirements, and unfortunately you would not get any points in the entire performance category. If you have more than the number of exclusions that are allowed for that specific measure, so let's say it's, you have over 100 e-prescriptions and 0 patients in the numerator, obviously you can't take the exclusion and you would not be able to get points for the performance category. So just keep that all in mind. Oh, thank you. My teammate Veronica just posted the link for the ONC tool, so that is in the chat. If you have exclusions that you can take, definitely make sure you take those appropriately. When you're reporting, if you go through this CMS QPP portal, which is online, free resource, and you manually attest to your promoting interoperability data, there are little check boxes to say you're taking that exclusion. Key piece for the exclusions, if you take an exclusion, do not submit data on that measure. So don't put anything into the boxes, just take the exclusion. This will also go for hardship. Don't enter any data into the performance category. That would basically negate your entire hardship exclusion. But we'll talk about that a little more later on. And then, as I just mentioned, make sure you're completing that annual security risk analysis or reviewing your previous security risk analysis. All right, I have a lovely scoring example. This definitely is a complex change to the scoring methodology. We've heard from some organizations that they anticipate seeing somewhere between about 10 and 20% decrease in their performance points for this measure, or for this performance category based on the way that the measures are being calculated. So just as a reminder, each measure, aside from the Public Health and Clinical Data Exchange, are numerator-denominator-based measures. Those Public Health and Clinical Data Exchange are attestation only, so yes, no, as is security risk analysis, but again, that earns no points. Each measure has a specific point allotment. So EPrescribing can earn you up to 10. Each of the bonus prescription drug monitoring and opioid treatment agreement, 5 points bonus. Support electronic referral loops by sending the health information is 20. Supporting electronic referral loops by receiving and incorporating the data is also 20. Providing patients electronic access to their health information is 40, and then the Public Health and Clinical Data Exchange is a 10 max. So, quick example, if we had a numerator of 1,278 and a denominator of 1,367 for EPrescribing, that would get us to a 93.49%, which would earn us 9.3 points. The query of prescription drug monitoring program, this organization had 15 of 21, so that got them to 71.43. Again, this is a straight bonus. It's really attestation only, but there is a numerator denominator obviously to it. So that would give them the 5-point bonus. They did not do the verified opioid treatment agreement, so they get 0 for that. For the sending health information, they had 157 over 298, which got them to a 52.68% performance and 10.5 points. Supporting electronic referral loops by receiving and incorporating the data, they had 130 over 302 for 43.05%. These are all made-up numbers, and that gave them 8.61%. So providing patients electronic access was 469 over 548, which gave them performance of 85.58 and 34.2 points. And then they did have the ability to send the immunization registry data, but they did take the exclusion for the syndromic surveillance data, which gave them the full 10 points for that measure. They did complete the security risk assessment, it's the analysis. So total for the category, they got 77.61 points out of the possible 100. Now, we saw a lot of organizations and clinicians getting the full 100 points in 2017 and 2018 if they did report on this performance category. So just keep that in mind. Obviously, these are completely fabricated numbers, so your practice might be doing better, worse. If you're looking at this thinking, I'm really just not sure how we're performing, now would be a good time to start seeing if you can pull these reports, see how you perform, see how that all stacks up to the new scoring methodology. We are more than happy to help you work through that if you have questions. But if you're coming up somewhere below 70 and you'd like to be higher, you can definitely start looking at that now and making those shifts in your workflows or documentation patterns to make sure that you have the appropriate documentation to get a higher score. Oops, sorry, skip the slide. Interesting. So if you, how does my score calculated is excluded from all measures that have exclusions. So if you recall, let's go back to that whole list. I'm going to jump back. Oops. So every measure except the provider to patient exchange measure, so the provide patients access to their electronic health data, has a possible exclusion besides the two bonus measures. If you are eligible for exclusion in every single one of those measures, you're probably thinking, well, geez, Leila, that gives me 40 points for the whole category. That's not going to help me. That only gets me 40 points of the possible 100. So if that's all the case, then all of the 60 points that had to be reweighted would go towards that provide patients access to their electronic health information. So that one single measure with no exclusions would become 100% of your performance for this promoting interoperability performance category. So just keep that in mind. I don't think we're going to see many clinicians or organizations that can take an exclusion in every single measure, but if that does seem to apply to you, please make sure that you're really working hard to get your performance and use of your portal up as high as it possibly can, because that will be the determining factor for how you perform in this category. All right, now I'm going to jump back. Okay. So I just want to briefly touch on the 2015 electronic health record technology requirements. So this is pretty key, and it's a little confusing. So 2015 CERT, or Certified Electronic Health Record Technology, must be fully implemented by the end of the Promoting Interoperability Performance category, reporting period, sorry, which is a consecutive 90-day period in 2019. So if you are in the process of implementing the 2015 system and you decide to use that final 90-day reporting period, which again goes from October 2nd through till December 31st, you would have to make sure that your 2015 certified system is in place, fully implemented, ready to go by December 31st. Now, I would highly recommend against that, because if any of you out there have ever worked on an upgrade or implementation of a new EHR system, typically getting data out day one that's correct and validated and ready to go is nearly impossible. And there's oftentimes a lot of rework that has to go on in terms of getting all your reports to match and pulling the data and so on and so forth. So I would highly recommend, if at all possible, that you really try to have your system implemented by at least the start of your reporting period, just to alleviate the stress and potential for errors and issues down the road. Now, you don't have to. That's not the requirement. But from previous experience, I would just highly recommend that you have it in place before you start reporting. Now, another component to this is, if you're using the ECXQMs, which are the EHR-related quality measures, as your quality measure data submission method, so that's the method you've selected, 2015 CERT must be in place by the end of the quality reporting period, which is the 2019 calendar year. So again, if you're using ECQMs as your quality measure submission method, you have to have 2015 CERT in place by December 31st, 2019. However, again, I would highly recommend, now quality measures are a full calendar year, so that makes it a little more challenging, but I would highly recommend that if you can get your system upgraded as soon as possible, you will save yourself a lot of headache at the 11th hour, right, when it goes from 2019 to 2020, trying to get the data reconciled, trying to make sure it's valid, accurate. Again, these are all you're testing for the quality and the validity of the data you're submitting to CMS. CMS does reserve the right to audit for up to 10 years. So just make sure, again, you're doing that gut check on your data. You're making sure everything aligns. Don't just blindly send the report to CMS. Make sure if you're upgrading or implementing a new system that everything ties out. You do a really thorough evaluation, even maybe an inter-rater reliability test where you can check to make sure you're all coming up with the same values and numbers, just to make sure it all looks good. So, special status considerations. We get lots of questions about this because it really can get confusing if you have an organization or practice that's multi-specialty. So, first component is for the special status consideration. So this is automatic relating for clinicians that are considered to be hospital-based, non-patient-facing, or ambulatory surgery center-based. Now, that is for individual eligible clinicians. You get automatic reweighting. If those clinicians are part of a group, that group still might need to submit data. So there's a couple of little caveats to that. So if you're working with a hospital-based group, 100% of the clinicians within the group would also have to be considered hospital-based, which are clinicians that furnish more than 75% of their eligible professional services under place of service 19, emergency department, 21, 23, and 24. And 24 is ambulatory surgery center. So they are included in there. The only piece of that is ambulatory surgery center-based clinicians. It's only 75% of the group has to be considered ambulatory surgery center-based. One little difference there. For non-patient-facing clinicians, it's also 75% of the group must be considered non-patient-facing. And these are clinicians that have fewer than 100 patient-facing encounters during the reporting period, and CMS does all of that back-end calculation. If you go onto the QPP.cms.gov website and you look up your participation status, you key in the 10-digit NPI code, it will show you right on the screen if you're eligible, if you have any special statuses, if you're eligible as an individual with special statuses or eligible as a group with special statuses. It gives you all of that breakdown. The next component of the special status considerations is for the eligible clinician type. So mostly I'm talking about as an individual reporting. Clinicians that are physician assistants, nurse practitioners, certified registered nurse anesthetists, clinical nurse specialists, physical therapists, new eligible clinician type on the right-hand side now. So physical therapists, occupational therapists, speech and language pathologists, clinical psychologists, audiologists, and registered dietitians or nutritional professionals, they all automatically get reweighting for the Promoting Interoperability category. However, again, just keep in mind, if those clinicians are part of a group that has any of the other eligible clinician types, such as MDs or DOs, those clinicians would still be required to report if they are participating as a group. So just keep that in mind, that the group doesn't automatically get reweighting just because you have mostly physician assistants or nurse practitioners. You need to look at the whole picture and say, okay, as individuals they're excluded, but as a group we all have to report data. So CMS will be offering another Promoting Interoperability hardship exception. This is available for clinicians that are part of small practices. You don't automatically get a hardship just because you're in a small practice. It's more that there are extenuating circumstances that have made it challenging for you to implement or upgrade your system. If you happen to be using a decertified EHR technology, you definitely want to submit a hardship exception application. If you have insufficient internet connectivity, extreme or uncontrollable circumstances, lack of control over the availability of certified EHR technology, that's really why all of those clinician types get the exception, is because they really don't have control over the EHR. They usually work in a hospital organization or system where they really have no control over the application that they're using. CMS hasn't yet made the application for the hardship available. It typically comes out usually like end of summer-ish, so just keep that in mind. And it is due back to CMS by no later than December 31st. We always recommend that if you're even considering submitting a hardship application, submit it sooner rather than later so you know whether it's approved or not, and make sure that you definitely don't miss that December 31st deadline. If you are eligible for reweighting, so any of the clinicians on this previous slide, or if you submit the hardship exception and get approved, your Promoting Interoperability performance category would go from 25% of your MIPS score down to 0%, which would move your quality performance category up to 70% of your MIPS score. So also keep that in mind. So if you're looking for reweighting, when 70% of your score is coming from quality, it's really important that your quality performance is really high, because obviously the majority of your points, over 50%, are coming from that one category. That leaves a few points coming from cost and definitely some points still coming from improvement activities. So you can get to a high score, but just make sure you're calculating what measures and methods to report. Just briefly, I want to talk about alternative payment model considerations before getting into questions. I see a bunch in the queue. So keep in mind, if you are part of a Medicare Insurance Savings Program Track 1, and just as a reminder, all of those MSSP tracks are changing middle of the year. But if you're in an MSSP Track 1, the Promoting Interoperability performance data is reported to CMS either at your QIN level, so your practice, or at your individual clinician level, if for some reason you're reporting as an individual. Performance is aggregated across the APM entity, so you get one score across the entire APM entity for your performance. Clinicians in the MSSP Track 1+, 2, and 3, so falling into the Advanced Alternative Payment Model group, also submit their APM or their Promoting Interoperability data at the TIN or individual level, and then performance is aggregated across. There is a 75% requirement that the APM participants use 2015 certified EHR technology, so just keep that in place. That is part of the Advanced Alternative Payment Model requirements. Next generation ACO participants do not have to submit any Promoting Interoperability data. That all gets lumped into their 75% participant use of 2015 CERT. And just quickly with the MSSP participants, the ACO 11, which was meaningful use of an EHR system measure, has been removed, but there is still the requirement for the Promoting Interoperability data submission. The Promoting Interoperability category allows for a couple different ways to submit your data. You can do that direct via an API or through your EHR vendor or registry. You can also go right into that CMS QPP portal that I mentioned. There's an option for login and upload. That would be uploading either a JSON, an XML, or a QRDA3 file, or login and attach, where you log in and manually enter all of your numerator denominator values. And finally, the Promoting Interoperability measure specifications for 2019 have been released. You can get them via the link on the bottom. This is what they look like. This is just one measure for the e-prescribing front and back. Great information, a lot of detail talking about the different certification requirements and whatnot. So if you're interested, definitely go and check those out. I'm going to skip just quickly over the questions slide. Here's my contact information. If you want to send me an email directly because you don't want to ask your questions either in chat or over the phone, you are more than welcome to. I will go through the questions in chat now, but if you'd like to ask a question over the phone, it is pound 6. So let me just get back up to the top here. Okay, so, oops. Oh, my little chat box disappeared. Hold on one second. Let me try to find it. Okay, so we have a question. In comparing the newly released Provide Patient Electronic Access to the Health Information Measure to the former Provide Patient Access Measure, I noticed that there is no longer a diagnostic image report section. Are these reports considered procedures, or are we no longer required to push diagnostic image reports on our patient portal? That's a great question, Carly. I actually haven't seen that component, but I would say some of the requirements moving from, you're right, the previous Provide Patient Access to the portal to the new Provide Patient Access to the data requirements have changed a little. They're not word for word the same measure. They're very similar. So I would say if you're not seeing that requirement of pushing those reports, then it is no longer a requirement, but I will definitely go back and look and get back to you. But thank you for bringing that up because that's an important component to not miss if it's required. Just a couple questions about the slide deck. Hopefully you got the links. I think Morgan posted them again. Another question for 2019, eligible clinicians get 5 points for using PDMP under e-prescribing. Can they also receive points under the Public Health and Clinical Data Exchange? Yeah, great question. Unfortunately, no. You can't use the PDMP as additional measures methods of submitting data to public health and clinical data exchanges. It's kind of double dipping, as you know, because you're using it for multiple things. So unfortunately, no. Because of moving to that bonus, that's where you get the bonus points only. PDMP measure involves a query into the PDMP. Yes, that's correct. Thank you, Veronica, for posting the ONC link. The other public health and clinical data exchange involves active engagement, completed registration, and submit data and testing and validation. Yes. I'm not sure if that's a question, but you are 100% correct on that. You do have to be actively engaged or at least have plans in place if your state isn't quite ready to accept that you've started doing testing or you're in the queue for testing. There's a whole process and algorithm you need to go through. And in those measure specifications, it definitely talks about the different elements based on whatever data exchange route you decide to take. How do we see groups handling the application of patient choice change for the portal offering measure? It appears that it will involve a third party. I apologize, Rebecca, I'm not sure I follow your question. Are you asking about for what I had mentioned with groups of patients that might not be able to utilize the portal on their own? If you could just respond back in the chat, I'll get back to your question. I see another question for the slide. So those, I believe, have been posted. Morgan, if you don't mind maybe posting that link again, that'd be great. Any other questions, feel free to ask them in the chat or again, #6 to ask over the phone. While we wait, I'm just going to go one slide down. We have a lot of resources. We have our New England QIN-QIO macro page. We also have an Ask a Question link there. There's a link to the CMS QPP website, which is great. They've done a wonderful job of trying to get 2019 data available on the website sooner. It took almost till the middle of the year last year, so luckily a lot of it is out already today. There's a link to the participation status lookup tool and the portal that I mentioned. Just a side note on the portal, because I have to push it. If you don't have access to the portal yet and you're looking to get access, you do need to sign up using the new HARP account. That's the HICS Access Role and Provider Profiles account. Just make sure you go through that process. If you had a previously activated EIDM account, you would just use your same login information and log in that way.
Hi, Leah. This is Rebecca. Can you hear me?
Yes, I can. Hi, how are you?
Good, thank you. Great presentation, by the way. So my question actually, I'm with Quality Insights, and I always love your webinars. I always get so much from them. So when you were talking about the provide patient access, and it actually says that the patients can view this through an application of their choice, does that mean they're incorporating a third-party application? Like it's not necessarily the patient portal that they have, but they can go out and download any application that was available in their app store on their phone or whatever?
So, yeah, so that's an interesting component now that CMS is trying to give EHR vendors a little more flexibility. That would be through that API, the Application Programming Interface. So it's dependent on what's available through the vendor, right? Because the vendor has to be able to push it to the system. And then from there, can the patient pull it down? So it's kind of multi-pronged, but yes, you're right. It could be a completely different third party, not affiliated with their EHR vendor. Lots of practices years ago used to do that before vendors became a little more savvy, I guess, with their portal offerings.
Thank you.
Absolutely. I see a couple more questions. Is there a lookup tool to check the status of your EHR? So I'm assuming you're looking to see if the EHR is certified and for what year. And if that's the case, yes. And I'm again going to look to my team to pull the ONC Chapel website link. The only thing I'll mention with that is it functions kind of like a shopping cart. So you need to know, one, the vendor, which I'm assuming you would know, but also the version or the module or whatever system you're using sometimes has multiple modules or components to it. You would need to make sure you're selecting all of those various components in the correct year because they can differ greatly. One might be 2014 certified, one might be 2015, or one might not be certified at all. It's really important to know where you stand with all the different systems that you possibly are using. Let's see, another question. Attestation period is only 90 days for everyone in 2019. Yes, Lisa, you got it. 90 days for everyone. It's pretty incredible that that has remained the case, but it's 90 days. We attested for a full year last year with expectation we needed a full year again with 2015 cert. Hey, you, I'm just going to say, are way ahead of the game. If you're already on 2015 cert, that's fantastic. And you, hopefully, when you see your 2018 performance, we'll see that 10-point bonus for promoting interoperability. But yeah, you don't need a full calendar year. If you can get it, sometimes you can see higher levels of performance with a full year versus 90 days. But you're only required to submit for 90 days. I see Karen has a question. Let's see. Will recordings be available for this link as well? Yes, they are usually available about a week or so after on our website. Thank you, Michael, for posting the link. My colleague Michael posted the Chapel ID website link. You can go in and check your EHR's certification. But again, make sure you have the modules you're using and any other pertinent details for your system. So a few more minutes. Feel free to ask more questions in the chat. I love hearing from all of you. And if you want to ask a question over the phone, it's #6. Or if you are shy and would like to keep your questions private, you're more than welcome to email me directly.
Hi, this is Steve. Thank you for the presentation. I have a question about the 2018 hardship application or exception application for small practices. It looks like it's too late now. I help out some providers, and I'm kind of upset about the way this is handled by CMS. That you log into QPP and it shows the status that the practice is a small practice. But yet you had to complete this application. yeah, it's already known your situation. And the more I read about it, it was like you could even put in data and they would ignore it anyways if you did the application. You know, a lot of people do work on this stuff up until the end of March. And just to have that sitting there knowing that you're going to get, you know, no credit for being a small practice at this point. I was told by the QPP Help Center that you may be able to submit something in May and have somebody look at it, but it's really not sitting very well with the providers.
So I just want to make sure I understand. So you have small practice clinicians that are identified as small practice when you go into the participation lookup tool, correct?
Right, right.
And then they were looking to get the EHR Promoting Interoperability hardship exception, but they didn't submit the application?
Right.
Okay. Yeah, so, I mean, unfortunately, so as I mentioned back on that slide with the hardship exception, it's not automatically given just because they're in a small practice, because some practices that are small still are really heavily utilizing certified EHRs, so it's not just given to small practices. You do still have to apply for it, unfortunately, and the deadline is December 31st, so they have missed it for 2018. The May time period that the person mentioned to you, which they might or might not reconsider, is usually during the focus review prior to final performance data being made available. But I can't say that's something that CMS would be looking at directly. So I would just say keep in mind any hardship you do have to apply for. So it's a really simple application. If you're working with small practices, I would say as soon as that application comes available, just have them submit for it if they think they might need it. But you do also bring up a great point that you can enter data and completely negate that entire exclusion. So just keep all of those little things in mind, but I'm sorry, I don't have a better answer for you on those.
Do you know why it's 12/31? I mean, any idea why they picked that day? I mean, because you can still, I mean, we're going to be putting stuff into the system up until March at some time, I believe.
Usually it's 12/31 because that's the end of the performance period.
Yeah, I feel like, you know, maybe I should reach out to my congressman. I mean, these small practices, no one notified them. You know, nobody, and they had no idea, you know, and, you know, now they go in this time of year to look back on the year, and you would think you'd be able to choose this. You know, it should be pretty trivial.
With, so my email's up on the screen right now. Would you mind sending me an email? I'd love to chat with you more offline about this and see if we can figure out a way to help them out going forward at least. We might not retroactively be able to help them, but at least get them some support going forward.
Yeah, sure. Thank you.
Great. Thank you so much.
Yep. Bye.
Thank you. Okay, so a couple more questions. We have certification for EHR that's 2014-2015. Is that appropriate? So, Judy, you would have to be on 2015, certified for 2015 by the end of the year at the latest. The website that we're posting, the link, if you scroll up about halfway through the comments, is listed. It's right on our Healthcare for New England, alloneword.org. And if you go to the events page, you can pull the information there for the webinar. The slides are currently available, but the recording takes a couple days, so just keep that in mind. Oh, great. Thank you, Morgan. Posted the link again. If you have any more questions, we have a couple more minutes. Happy to take any last questions you might have, or feel free to ask them over the phone. It's pound 6, or you can email me.
Leela, while we wait to see. Oh, go ahead. Go ahead with your question.
Oh, Lila?
Yes, hi.
Hi, this is Tim Ringo. Lila, I just wanted to make a point here. Just because we have an EIDM password and we were connected last year, we attempted to go through the new QPP site. It's not seamless, and we've been about 3 weeks now trying to get into that site, and they can't figure out why we can't get in. So I just wanted to bring it to your attention and all the other participants. Don't wait till the last minute to try to get in, because if you get into that situation, you may find yourself in trouble not being able to get into the site. So.
Absolutely. Thank you so much for bringing that up. And that is a point we've heard from a few individuals and organizations that you're right, the EIDM doesn't necessarily carry right over. All your data isn't present when you actually get into the portal itself. So we're still in January, Leslie, only 16 days in, and with about 2.5 months left in the data submission window. So if you are going to be submitting data for clinicians or yourself or an organization, please check your access now, and if you have issues, get into the queue. Unfortunately, we can't work through those with you. It's something on the CMS side. They have to connect all the dots, but we're happy to help you get to where you need to be. So thank you for bringing that up.
Sure.
Morgan, did you have anything you want to add?
Yeah, I was just going to do a quick closing announcement. If there's still more questions, we can stay on a couple minutes late. But just as a reminder, we are on social media. I know Leila has mentioned our website, but visit us on Facebook, LinkedIn, Twitter, and YouTube as well. As you close out of the webinar today, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to do it right now, you will receive an email tomorrow containing a link to the evaluation, as well as a link to the event page, the one that we keep putting in chat, where you'll be able to find the slides that are already there. And then, as we mentioned, the recording and transcript will be added within the next few business days. So again, we can hang on for a few more minutes if there are more questions. But thank you, everyone, for joining.
Absolutely. Thank you all for participating today. Great discussion. And if you have any additional questions, comments, concerns, please feel free to email me directly or use our QPP.org website, ask a question link. We're here to help you make sure you're successful with all of your QPP NIPS APM reporting. So thank you again. I think that's it. Have a wonderful rest of the afternoon.